Another announcement on the junior group, so give it 1 minute.
Okay. Okay, right, let me share my screen with you guys, and then yeah. So this is an old but gold case. So this one was a while ago. You can tell because it's not my kind of classic layout, if you like, my specific design. But this lady is a 37-year-old with a BMI of 35. She is a para 1 who had a forceps delivery 11 years ago. O positive blood group, virology scat, completely normal. She came into triage at 36 weeks, attended for abdominal pain, and proteinuria was noted. She sent a PCR, which was 62, but her PET bloods were normal. So she was asymptomatic, but for weekly DAU appointments for monitoring due to the raised PCR. And she had an induction of labour booked for around 38 weeks. Last ultrasound was at 33 plus 6. Placenta anterior high with normal fluid growth and Dopplers. And I think the centile was normal for this baby as well. Very much average. So she arrived to antenatal ward with a plan for induction of labour due to her raised PCR, which had actually downtrended to 49.5. So this is her CTG before she...
Sorry if I'm interrupting. You said she's asymptomatic, yet she came with abdominal pain.
Yeah, the abdominal pain wasn't really caused by anything that we could sort of discover.
So it wasn't like a right upper quadrant pain or any
no
above PET. Okay.
No, just I think general abdo pain. But yeah, they obviously noted the proteinuria, but she didn't have any further problems at all with it throughout the pregnancy. And OS was closed at this triage appointment as well, so obviously not to do with anything laboury. Oh, so this was her CTG prior to commencing induction of labour, and she reported good fetal movement here. As you can see, criteria met at 26 minutes. What would we say the baseline is here? Anybody else want to have left it on for a little bit longer, just to better determine what the baseline was?
Yeah, I would have. So, I mean, the antenatal CTG in dose Redmond is essentially better than our eye. But what dose Redmond doesn't do, this is a basal heart rate, right, which is not the baseline rate. And I, at the moment, struggle to define where that is because there's also no kind of fetal movement documented. So it's not that the woman essentially kind of says that. So, so at the moment, it might be what 140 with lots of accelerations and then therefore really bouncy. Or but you know, I struggle a bit with the baseline rate at the moment. So might very well be 146, but this is, as I said, a basal heart rate, which is not the same.
Yeah, I definitely agree with you, Dagmar. And also, you know, if we're looking at baseline heart rate, we want the baseline to sort of sit between at least 2 to 3 minutes in one particular place. And I don't think it does that very well here. Because you could also argue, I think, that actually the baseline here is 160, and this is a sort of collection of decelerations with a prolonged in the middle as well. So yeah, definitely would have left it on for longer, but I think the reassurance that Dawes Redman gives us sometimes, although absolutely fantastic, is taken very much as a it's met, so it's absolutely fine. But I say this in pretty much every single one of these, you know, our eyes and our assessment itself is sometimes just as good, if not better, than a computer. But it was removed. This was the sort of CTG we've got as a baseline here.
Cara, just to note on this, with this CTG as well, you could visibly see that the baby was moving, so we were reassured for that reason.
Oh, okay, cool. Fabulous. So 1845, Propus was inserted. She was 1 centimetre dilated with a Bishop's score of 2, and as you can see, the CTG sort of settles down to around 145, 150 is the baseline. Anybody got any concerns or anything?
Do you and Croydon document in your antenatal notes what the kind of baseline rate of the baby is during antenatal clinic appointments?
So every single antenatal appointment, we write the fetal heart rate in paper notes, and then when they come to our antenatal ward, we have a tick box system on Cerner, and that's where we would sort of identify the fetal heart rates and put them in there.
So therefore, is this, which at rest looks like 145, 50, and then essentially during activity 150 more. Is that a normal base rate for this baby? And I didn't get the gestation at the beginning, so
38 weeks.
38 weeks, okay. So is this normal for this baby? It's otherwise on the higher end of normal. And it looks like cycling. And it also looks like acceleration, and the fetal movements were visible, and it all essentially kind of looks good, except for, in order to determine the baseline variability, don't go by norm rates, go by what's normal for the baby. And hence look at previous CTGs or previous antenatal care details. That's how I was always go about that.
Absolutely, thank you, Dagmar. So this was at 1845. Oh God. Oh. There we go. Sorry, this was at 1845, so it was continued for 44 minutes. I'm not quite sure why the Dawes Redman criteria was put on, considering that is not part of our guideline. It may have changed since then, but I don't know what you guys at other trusts do, but we don't use Dawes Redman at all after any form of induction has taken place. It could have been an accident, which happens very, very, very often. But yeah, obviously we're not taking the Dawes Redman criteria into account here, considering she's no longer sort of a true antenatal CTG. And yeah, as Dagmar was saying, obviously we've got the reassurance of accelerations and whatnot. And if we've been feeling fetal movements too and seeing them, then yeah, all reassuring factors, which is fantastic. So yeah, this finishes now at about 7:36. She's put back on the CTG at 0045, and this is your CTG now. Again, Dawes Redman's been used, and the STV's very clearly been highlighted, although completely irrelevant. You can see that she's having some contractions now, so clearly the ProPES is working, which is what we want. But what about our CTG here? specifically the last 2 minutes. Anyone want to take, everyone happy to take that off?
No, I'm not happy to take it off
Why?
because it looks like with the last contraction, it was like a deceleration and baby was slow to recover to baseline after that.
Perfect. Anybody else?
I would just find this very hard to interpret. I certainly wouldn't be comfortable taking it off because I just can't really work out a pattern.
Yeah. Perfect. I think we're all pretty much in agreement here, but I think again, this is one of those, Dawes-Redmond's met criteria, and although it's not supposed to be used in cases like this, I think we do get a lot of reassurance from it sometimes. So yeah, this is not one that I would have picked, that I would have taken off personally, considering the fetal heart rate was actually down for, well, above, if our baseline is 140 or 145, that fetal heart rate is down for at least a minute before it sort of comes back up and settles back at baseline. And actually it looks like it's risen slightly as well. So yeah, definitely wouldn't be happy to take this off at this specific point, but it was. So we will continue.
Also, Cara, with this case as well, just quickly going back to the other one, is there was some false reassurance. You see the clicker thing at the top. This is before we had the clickers, or we might not have had clickers that were working. So it was falsely reassured by the midwife that she was happy to take it off because they looked like there were signs of movement from the baby. So that is another reason why. So just being aware and asking obviously the mother if she is having movements and sort of taking that holistic whole picture into account when reviewing the CTG as well. So when we're just looking at it and eyeballing it rather than actually asking the mum.
Perfect. Yeah, absolutely. Oh God. Okay. So it's now 4:50 in the morning. Any thoughts on this one? She's
What
taken
has happened to the variability?
Good question.
That's my comment. What has happened to the variability in that time?
I mean, this is only a difference as well of about 3 hours. I think she was quite distressed at this point, so she was put back on the CTG. And yeah, this is what we've got now.
It also looks as if your base rate has risen. So at the end, it's difficult to kind of say, or baseline rate, sorry, where it is, because there are too many decelerations of loss of contact. But it starts with a baseline rate of almost 160, then 150, and reduced variability. So yeah, definitely keep it on and make the monitoring better. So and given that she's contracting like a super trooper, we'll find out how far she is, no?
If I'm the midwife on antenatal ward, I want this woman to be on a continuous CTG. So this is a point where I would be escalating for a review, and I'd be speaking to my midwife in charge and saying she probably needs to come to labour ward because she needs to be continuously monitored, and probably her being on the antenatal ward, being continuously monitored, isn't probably the safest place for that.
Well done, Sophie. I was already on labour ward. Typical obstetric error, no?
Yeah, see, you're always thinking you're on labour ward.
Yeah, sorry.
This lady is a BMI of 35, isn't she?
Yeah.
And she was in distress, so she could be hyperstimulating for the past few hours, and then obviously we're not picking it up. So if she's been hyperstimulating for 2 hours, it could be that. So I think if I was on antenatal ward, I would just examine her straight. If I'm assessing and I make an assessment that she is hyperstimulating, obviously I take, manage hyperstimulation at the point and take her straight to labour ward, but then obviously I might as well give her terbutaline at the time. She could have progressed. She was para not, wasn't she?
Para 1, forceps.
Para 1. Oh, para,
Yeah,
sorry,
11 years ago.
Okay, so I mean,
Labour ward.
we need to escalate and assess immediately. See if this is hyperstimulation or she's progressed. Obviously, PET we should keep in the back of our mind that it could be relative placental insufficiency. So that's all combinations of factors that we need to take into consideration. She's high BMI. We could have not been able to pick up contractions on the TOCO as well. So I think that would be my initial assessment for her.
Yeah, also there's quite a lot of loss of contact on here as well. Obviously she does have a slightly raised BMI, so an FSC would be kind of an ideal situation at this point as well.
Yeah, but she's got intact membranes, doesn't she?
Oh
'Cause
yeah,
she's
good point.
induction. Yeah, so then you're even more in a sticky situation because you don't want to ARM because that is going to obviously increase contractions. So I stand by my plan. Get this woman to labour ward.
Perfect. Yeah, I totally agree. She is on labour ward now.
So just before this one, sorry, just to interrupt you, the CTG beforehand, they examined her on the antenatal ward at about 05:30 and she was 4 centimetres. And they took the ProPES out and the decision was made to transfer to delivery suite. So she didn't have a CTG in that point. It was just the fact that she was cracking on and she was in a lot of pain. So delivery suite accepted her. And then on delivery suite, this is the first CTG that she had. So obviously we're in the right place, but this is where we are. Sorry, Cara.
No, it's all right, mate.
Sorry, guys. What time did the ProPES come out again?
Probably the same examination. It's about 04:35, so about 20 minutes before this, when she was on the antenatal ward.
Cool. This is your next trace. So this lady's requested an epidural and the test dose is given here at 05:24. Obviously lots of loss of contact here whilst the epidural was being cited, as well as the fact that obviously the BMI is going to contribute to that. And she's actually re-examined at 05:39 and she's fully dilated and oh, for goodness sake, fully dilated and an FSC is placed at this point.
So she shrommed at some point in this transfer.
She shrommed at some point,
bless her. Oh, it's just like everything sort of is happening at 100 miles an hour.
Yeah, it was a good, it was clearly a very productive batch of ProPES as well, which
but seeing this CTG, and with the management of putting an epidural without an FSC, for someone that works on labour ward, I can now tell you that the practice has changed. So monitoring the now is more important than getting an epidural in quickly, because we want to see where the baby is, because sometimes you put an epidural in and you end up in theatre anyway. So you'd want to know where we are rather than monitoring the baby rather than putting an epidural quickly for the woman. So that has changed now. We're more towards putting an FSC, establishing where baby is, and then getting the epidural in.
Yeah, and I love that because I have many less problems with lacking CTGs when they've been abnormal beforehand or suspicious or pathological beforehand, and then an epidural gets cited. So I think we're all moving in the perfect direction. Just from a human factors perspective, before I do go to the next slide, the person caring for this lady was a very junior band 5 preceptorship midwife. Our central monitoring, I don't believe, was working either in the room where this was taking place. So just take that into account. Obviously now this woman is fully dilated, so preparing everything in the room and whatnot, and getting everything organised before baby makes the appearance. Just something just to bear in mind before I show you the next slide.
Sorry, I'm having trouble connecting
just
to the
before we move
internet.
to the next slide.
It looks like a router issue.
Sorry,
so try restarting it.
What is that?
Unplug the router Wait 10 seconds. Then plug it back in.
Alexa. Sorry.
I don't know. That's from you, I guess, isn't it? I just wanted to know from the previous slide what people are going to write on paper. Like if people can shout out, what are they going to classify this? So for the last 20 minutes, I'm interested in knowing, obviously, what are you going to document? What are you going to classify? Obviously abnormal, but I want some more information of what people think and what names they're going to put and what they think is going on, if that's okay.
Absolutely.
Because later on, I think we need to move to management of how you're going to, she's fully, so we need to kind of also chat about what we're going to think the best management here as well, I guess. Anyone happy to contribute?
I would say subacute hypoxia at this part of the CTG. Again, I haven't got enough because of the loss of contact for me to say that, wholeheartedly, but I would say it's subacute at this stage.
Yeah, I agree.
I triply agree. And I think delivery, well, actually, going back to, if we go back to the previous slide, just as Sophie was sort of saying, when we move to this sort of segment here, the variability is very, very, very poor. Although baseline appears to be somewhat stable. As she's sat up for an epidural, she's obviously clearly in distress, and we're not getting very good contact. But then as soon as it starts to go much more southward around 05:35, and we can see very clearly that our previous baseline's not really, our previous fetal heart rate's not really coming back to where it was before at our baseline. Subacute hypoxia, possibly giving terbutaline to calm down the uterine contractions, although she's fully dilated and we know that we could deliver baby quickly, seeing if that gives enough of a rest could be an option.
Do we
Otherwise,
know that? At the moment we only know fully dilated, but if this baby is -1 OP, then that might not be an easy delivery. So therefore, do we have any further information regarding the fully? Because in the end of the day, if we have subacute hypoxia, we have two options, no? Either in utero resuscitation or delivery. And you make that decision based upon your examination findings, no? So therefore, that would be an important information. Because do you use terbutaline? Do you just essentially, depending on what the CTG kind of says in the next couple of minutes with a better contact.
Yeah, I think that's what I was trying to find out. If obviously, depending on the examination here, is our management plan. So I think, as Dagmar rightly said, so there are signs of decompensation now. We're time limited. So if this baby is at perineum, is one arm of management, but if it's at -1 OP, it's a completely different one. Sorry about the background noise. Any idea what the findings were on VE, Clara?
Spines. Baby's position was at spines with no kappa and no moulding.
I've had no time. It's just progressed quickly.
And supposedly OA as well. Does that change anyone's idea or thought?
For me, I just feel like this epidural that was put in at the risk of monitoring the baby could have waited, because the woman was progressing quickly anyway. So at this stage, you could either then decide to, well, we don't know what happens next, but I feel like the epidural took precedence more than monitoring the baby.
Yeah, but I mean, we see that on, well, not as much as we used to at all, but we see that, and we have seen that previously on a multitude of different occasions. Because people just kind of assume, oh well, it'll be fine, we've got to get this epidural and that's a priority. And again, just mentioning the fact that we need to make sure if our anaesthetists are needing support from anybody, that they're getting them from the ODPs and not using our midwives as our priority during an epidural sighting is to make sure we've got good fetal contact and good fetal well-being, essentially. But yeah, I'll move on to the next slide. What do we think of this one?
Good CTG is what I'm thinking, but horrible to look at. I mean, you have now what the looks of it, a kind of baseline rate of 180. You do have essentially prolonged decelerations. If I'm counting, they are 1, 2, 3, 4, 5 minutes. They recover with the 6th, the one in the middle. So that the contractions seem to be essentially kind of confluencing, and therefore the kind of deceleration show no recovery in between, but are therefore long. And I think whichever definition you use, let it be more, that's either subacute hypoxia or, according to NICE, a pathological CTG, or whatever you want to. This is nothing that the baby can sustain for a prolonged period of time. So given that the variability on the baseline rate doesn't look brilliant, although it's still okay within the deceleration, I would like to know what they're doing in the room, because this would be the time where I would normally expect to be escalated to if I was the registrar on the outside. To whilst the midwife in the room is essentially kind of saying, well, I don't know if she's pushing, just try to breathe through on the left lateral, or whichever position makes the baby happy. Is the epidural kind of working nicely? I'm going to kind of escalate to the kind of doctors on the outside. They might want to decide to do an instrumental just because your baby is in a kind of state where it really doesn't like that for much longer. Do you have any preferences? And then essentially already kind of get the prep, because really you either have the chance of making it better or delivering. And
so just for a bit more context at this point, the midwife is just preparing the room. She's semi-recumbent, the epidural is working, but obviously the woman's feeling some pressure through it, and that's pretty much it.
And empty the bladder. So she's not pushing. It's essentially kind of get her set up and get this escalated. And not in a please come in 15 minutes time, because you have now half an hour, almost 40 minutes of subacute hypoxia with a kind of good base rate rise. So therefore this is a consider pulling the emergency buzzer if you want to have attention.
I think the focus here by the midwife was on making sure everything was ready for the baby's arrival, as opposed to actually looking at the CTG. And there wasn't any additional eyes on this at this point, so difficult one. We'll go to the next slide. It works. Oh, sorry. There we go. That's the next one for you.
Awful.
Yeah.
Barely any time at the baseline, completely subacute, reduced variability. I'm sweating looking at it. It's just
it's honestly
here. I want to
decompensating. So you really do not see the CTGs often. For that purpose, they are fantastically educational, but it's awful to kind of watch. So yes, I'm with you. I would like to have this baby, out. And this is now also going on for another 30 minutes. So we're now at 40 and 30. We're at 1 hour, 10 minutes of this.
So Clara, is no one aware of the situation other than the midwife in the room?
Pretty much, yeah.
Okay, right.
Yeah,
I know
not good.
Why are we still in the room? What are we doing?
Nothing. We're still in the room. We are preparing the room ready for delivery, and I think she's going to start. I think the plan was probably for an hour of passive descent to start pushing.
What was the
midwife at this point?
Midwifery thoughts. What were the documented midwifery thoughts? I know that you said she's a junior person and the central monitor is not working, but
there weren't there wasn't really anything going on other than the fact that the midwife was writing her notes at this point. Apparently staffing was quite bad on this specific day, so she knew she couldn't get a fresh eyes. I think if there was a fresh eyes at this point, the second midwife probably would have had a heart attack.
Absolutely.
But yeah, everybody was caring for their own women at this point, so the midwife thought, okay, I can't get a fresh eyes, so we'll just continue. We'll give an hour of passive descent, and then
But
then yeah.
How are we here? Like, are we not training these midwives well enough for them to be able to do this?
This was quite a while ago. But yeah, obviously it's just one of it's one of those cases where it's complete distraction from looking at the CTG at all, really.
I think just bring it back to when you were brand spanking new as a band 5, and your priority sometimes wasn't the CTG, was it? It was making sure that you feel competent.
Absolutely.
And actually, it's going back to sometimes you might not feel confident going to that midwife in charge who might look scary, might look daunting. When you're a band 5, you sometimes just want to feel like you can get on with it. It's 6:40 in the morning. You're thinking, right, it's nearly over. I don't know how my shift has been throughout. I just want to get through this. I want to get my notes up to date. I want to get my room prepared. I'm not excusing this, but at the same time, let's put ourselves in her shoes. Because sometimes it can be quite difficult. It's fantastic we can learn from these cases, but actually we do have to just look. We're great, we're looking back on hindsight and we can say all these wonderful things, but actually put ourselves in that position in that room. You're tired, you've just done 11-hour shift so far and you're here. So I think like we obviously have to take that on board as well. And it's a fantastic learning opportunity for us now, but for her as well, just thinking about that and that human factors element. And this can still happen to our band 5s now. So it's making sure we do feel that we are empowering them.
So are you essentially kind of saying, and I'm just kind of to conceive if this could be established as a learning, I'm sure you have your learning from this kind of case, but if you do have essentially such staffing short of, or if we have such staffing shortages and therefore essentially have people that are potentially kind of uncomfortable or very junior in the rooms and the central monitor is not working, what should at least still happening is hourly fresh eyes, no? So that nobody essentially, even if they kind of get a bias, no, because you sometimes really don't see the woods because of the trees, because of distractions, or because you think, oh, this must be normal, or because you're elsewhere, no. So there are many reasons, and it happened to all of us. But then what is essentially our kind of network in the system for this not to occur? I mean, great, we evidently all kind of agree that this is a highly abnormal CTG. We would like to have the baby delivered. But the staffing is the same, and central monitors can fail, no? Systems can fail, humans can err. But the query is essentially, we still have the hourly kind of fresh eyes, isn't it? So when did they happen the last time? Are they kind of due any time? Do we, and we now have also escalation aids. So about if you're uncertain, about what do you need to kind of check? You need to check in the first instance the woman in the room, no? So depending on her well-being, then the baby's well-being, and then what the situation is. And I think that's the sort of assessment that we need to do all the time. And I think obstetricians are not very good in checking what the woman does. No? So we look too often at the kind of CTG. And I love, therefore, that is very often balanced by, when I was just kind of saying my comments earlier and I was already on labor ward, that's not necessarily where it all happens. But, it's essentially then the kind of contribution, because only as a team we make it. So how else can we make this better?
So from this case, we were quite lucky that actually from this case, we were able to understand that we weren't giving the correct support. So it's reaching out to the coordinators and obviously getting them know, okay, we need to check on the band 5s a little bit more. So this is a few years ago now, so I'm not too sure if that still happens in Croydon. But obviously teaching staff the importance of the RCOG, each baby counts, the escalation tools, pointing them in directions for that as well, which is really, really important.
Good, excellent.
Perfect. I'm going to give you this is the next slide. I think she's pushing now.
So the midwife in charge came in the room at 6:42, I think it was, to see whether or not she had delivered. And what they found, she saw the CTG and thought, okay, we need to get things going. So obviously encouraged the woman to push to see if there was any descent and things, if anything was happening. She was pushing effectively at this point. And she highlighted, so she popped out of the room again, just highlighted to the obstetric registrar that was in another room at the time, who said, okay, see if there's any further descent with contractions, and then I'll be in the room in a couple of minutes. So they continue to push, and actually, as you can see, at 06:50, I started noticing sort of vertex, and head was descending quite well. What do you think so far? I want to take over.
Sorry, when was the vertex advancing or on the perineum? I didn't catch that.
06:49, 06:50.
Thanks.
Anyone want to guess the APGARs and the gases for this case?
And delivery.
So did she deliver at kind of 7 o'clock then spontaneously, or it looks like 7:01 is the last bit that I see, although I can't make out if this is maternal or fetal pulse.
I think it was 7:01 that the baby was born.
How many minutes of kind of subacute did we have right now? So just for I mean, this seems to be
from about 05:35.
So at 05:40 did we start? No, 05:40 to 7:01.
I'd argue it's 05:35.
Okay.
Well, so pretty much an hour and a half.
Minutes, but it's an hour and a half, right? Okay.
Yeah.
Well, I think this baby had a kind of good going negative base excess and slightly raised lactate. There will be a difference between the kind of venous and arterial one, because this is kind of indicating fall of pH. So if we say it started with an entirely normal one venously at 7.35, no, or 7.3, let's make it round. And then we essentially have every half an hour, if we say that this baby is really fit and maintain that for a long period of time, half an hour fall by 0.01. Sorry, I'm speaking out loud because I right now have nothing to kind of write on. So therefore, we essentially had a fall of 0.3. So therefore, if you are conservative, you think that the arterial gas is 7.0, it might be 6.9, and I hope that you had peds somewhere along, because this baby might need some help. And if it is essentially, if this variability, which is difficult to interpret at the end, kind of indicated that there was essentially no decompensation to brain function, and it will perk up at 5 minutes. But yeah. But that is, so the variability in between looks actually really crap. So I'm at the moment not sure. I wished I had stun on this trace. Oh, yeah. That was essentially kind of my thinking. So this will be an hypoxic gas. Yeah.
But then if you did have Stan, would have given you an event ages ago, probably.
You don't know, no? So that's essentially that's the kind of part where Stan can help you to kind of decide that, because I've seen horrible subacute hypoxias with no stun events, where we quite literally stood on the outside just waiting for this kind of to go off, and it never did. And these babies came out and the CTG looked awful. So we know that about 50% of these babies are fine, regardless of how shitty it looks. So this is where stun is helpful. So, but you know, this might very well be a good going kind of metabolic acidosis, yeah, because of the duration.
Get us out of our misery, Cara.
Oh, computer's frozen. You're never going to learn the gases. There you go. Arterial pH of 7.12, base excessive -6.9, and a lactate of 6.3, and a venous of 7.22, base excessive -6.2, and a lactate of 5.1.
Fantastic buffering, but the lactate is high and the base excess shows that this baby was buffering, but good going placenta, excellent.
I know.
Yeah.
Very.
So as I said, you know, I always kind of say hypoxia is the kind of easy part, but you know what? Particularly subacute is actually really difficult unless you have additional tools like stun. For that, I like it. I really like it a lot.
Just going back to what Sorsha said earlier on about thinking of the newly qualified midwives and what she was thinking. I think if I'm to put myself in the situation of either the coordinator or the band 5, I can hear someone saying she's a mole tip, she'll deliver quickly. I can hear, because that's probably the reason why this subacute episode was allowed to go as long as it did. Because we, as a junior midwife, you always hear, oh, why hasn't she delivered? She's a para 1, and actually forget what is happening in the room, what's happening with the woman, and what's happening with the CTG.
No, that's, absolutely. Baby was born with APGARs of 9, 10, and 10 as well, by the way. And was discharged at 12 hours of life with no concerns or problems. This baby compensated within an inch of its life, and did so very, very well.
I think one of the kind of nice bits, and very often about the Oldie and Goldies is not because you normally have all the outcome data, but the thing is, CTGs the learning from CTGs is not only from bad events, but also from kind of events that have a fantastic outcome, but where you think you just kind of got away, right? Because ideally we shouldn't be getting away, we should be safe. And not do interventions where they're not needed. And this trace, I'm ever so sorry to kind of say so, and I don't mean that critical, but that leaves me right now with the kind of sensation, oh, we were lucky, no? Because we had quite literally nothing based upon what we can see on a CTG without any additional tools that gave us the reassurance of this baby being not kind of centrally compromised. So I struggled to kind of see that. And based upon the comments that I heard, I had the impression other people had that too. And it's not because we don't know what we're talking about. This is the kind of limitation that CTGs have. And then if we know and acknowledge that we have the kind of limitations, then it's still about kind of playing it safe. So I would have essentially liked to kind of put the FSE on, you know, feel that people are supported and can escalate. So all of the things that we have learned based upon all the initiatives from fetal well-being networks, each baby counts, communication, no? RCOG and Royal College of Midwives, and then essentially avoid such sweaty moments because I think we were lucky. I'm so glad. But it feels very lucky, no?
Yeah.
And that is not what it feels like. It should feel like I did that well, and I enjoy the kind of fact that we have a mum and a baby who just enjoy kind of the time together, because gosh, that was nice and safe. Yeah.
But really interesting and really excellent learning, and actually brilliant that it was a good outcome, because this can be positive learning rather than actually someone's been involved in a horrendous risk review and a really bad outcome in an HIE, this is the type of learning that's you catch it.
Yeah.
And actually you can feed back, and it's not as bad as something really catastrophic and terrible happening.
Yeah.
That upsets
No, absolutely.
everybody involved.
Which though, yes, I absolutely agree. And I have one question for the kind of group, because I very well know where we have the kind of data from for the acute hypoxia and the fall of the pH. So plenty of kind of references, but I struggle a lot more with the subacute hypoxia and the fall of pH. Has anybody actually ever seen the literature for that?
So that for the
No.
what, Dagmar?
For the 0.1
Oh,
every 20 to 30 minutes.
In SAA.
No, but you never know. You never know what it started off with.
No, that you do know. So it is, if you essentially had no significant degree of hypoxia, then there is essentially no evidence. I mean, there are this kind of sheep studies, no, and they say that the kind of baby, to a certain extent, buffers this gradually evolving hypoxia has been going on for a long period of time, because there is, you know, to a certain extent, some degree of there are always chemoreceptors involved in decelerations. There's always some degree of potential kind of lactic acid and buffering. So, you know, so here we go. But we haven't got any kind of evidence that with gradually evolving hypoxia, without any of this kind of other schemes that happen, that we have any significant acidemia. No, right? And we even in kind of bad traces, as I said, only have about 50% acidemia. So it's not always resulting in a metabolic acidosis. But when we look into acute hypoxia, there is actually kind of fantastic evidence from observational trials in humans that essentially kind of calculated based upon, you know, the kind of average normal pH to the when it was delivered. And then you can calculate the fall per minute, and that is where it's based upon. But the evidence for a subacute hypoxia is more difficult to find, and I was recently just kind of trying to kind of nail this number down, similar to what I was trying to kind of nail the number down of 10% rise in base rate, because St. George's uses 20, no? So where does this come from? I know it comes from where it comes from with temperature, and that has a kind of very physiological explanation, but not really with kind of evolving hypoxia. So therefore, my question to the group, have you kind of got any literature that you are able to kind of pass on for the kind of fall in pH and subacute hypoxia?
Absolutely none.
No.
Okay, because then that is my homework to find, because that has been annoying me. And then I have Kara's email.
Thank you, Dagmar.
I'll pass it on to you. Okay.
And then you can tell us all. Yeah, exactly.
Yeah.
Yes, will do.
But you know, this is very scary if we're practicing things that actually you don't even know how they originated. This is actually quite scary. Like we're doing things that we don't even have evidence to how they started and how they're initiated.
No, I'm not saying
Yeah,
that we don't have
yeah.
any evidence. It's just that I at the moment struggle to find it. But it is that CTG.
But if you can't find it, that means it's based on something very weak. If we can't find it, because obviously if it was a good evidence, that wouldn't be the problem.
Well,
It could be one study or one observational study, and then that's it.
Maya, you are practicing. So ultrasound scan. So CTGs have been in use since 1962, no? Approximately. I mean, with lots of kind of technological advances. The first guideline that was essentially kind of published by the RCOG, and I know that because I'm old, right? Oldie goldie here. So about how to interpret a CTG to kind of bring any kind of standard into this was in 2001. So therefore, we're talking more than 40 years after introduction of a kind of technical tool that we made decisions based upon and conducted cesarean section based upon. There was no kind of evidence for this. So therefore, the way how CTG essentially kind of came into use would kind of gray your hair nowadays. But so therefore, the majority of stuff regarding CTG is not based upon evidence at all, but it was essentially expert opinions. And then essentially all of the kind of grading system came in, and then the kind of trials came. But so what many trials in the kind of 60s, 70s, 80s, and 90s were about, no? Were about intermittent auscultation versus CTG, and you all know that they have essentially never shown any difference. So the kind of evidence for kind of continuous CTG is actually very poor, other than it reduces seizures, which is also the kind of and they haven't been repeated since 1985. They haven't. So we have nothing that can compare that. So and that's, yeah. So evidence is something that we talk about more and more since essentially the NICE guidance in 2017 came out, and so much uproar was there because it was not practical, and it was essentially complicated, and no evidence was for that. And I mean, we still essentially have now in the NICE guidance the use of FBSs, which has no evidence base. It doesn't. So, you know, do it in a study, but don't use it on kind of people in labor. But it still is there. So therefore, I would always recommend, and I know I'm sounding a little bit cynical, and I apologize for that, but I love the kind of CTG meetings and the kind of talking about monitoring. I love that we talk about getting women involved and essentially at the center of the care. I love about this talking about teamwork because it makes us think. And that is essentially how physiological interpretation also came about. Think, why is it like that? Don't follow a pattern and understand what the baby is telling you so that you can predict, not only react. That was the origin, really, no? Because yes, in many areas the evidence is rather poor, Maya, and I didn't mean to kind of frustrate. I'm essentially just kind of saying it's on my homework list, and it might be there. It's just that I just now don't know that, but that just kind of tells you about my ignorance and not about that it doesn't exist. So my own feedback.
No, but this is actually good, because obviously meetings like this can be the you know, the nucleus of starting, for example, a group to kind of challenge things that we always took for granted. So even if we kind of like search for evidence, that I think, in my opinion, that's enough to kind of like look back and see where things have started. So thank you so much for the wake-up call, Dagmar.
Perfect. Thank you all for coming. Yeah, and yeah, Dagmar, if you do find anything, then please definitely send it my way. But yeah, I'll see all of you guys next week.
Thank you.
Thank you,
Very
Cara.
interesting
Thank you,
case.
bye.
Thanks, Cara.
No worries.